Hello, everyone. My name is Dr. Javan Bass. I would like to first thank you all for attending this webinar. We are here to discuss the standard of care for patients with onychodystrophy. There are a few takeaways that I would like to first discuss. Following this webinar, I would like for everyone to have a better understanding of the causes of onychodystrophy. I would like for everyone to have a better understanding of the risks of empiric therapy. Oftentimes, as a podiatrist, when we see onychodystrophy, we decide to treat empirically with whatever our standard oral or topical antifungal is of choice. There are definitely risks associated with that, and I want to make sure everyone has a better understanding of what those are. How do we avoid empiric therapy? Well, our testing options. I'm going to go over our testing options. I'm going to give various recommendations for how I decide to test, what tests that I perform, when, and why. And then we are definitely going to go over some nail collection techniques. Okay, well, let's get into it. So, onychomycosis, what's all the fuss about? Well, you can't discuss onychodystrophy without discussing onychomycosis. Why? Onychomycosis, the most common disorder affecting the nail unit. 50% of the time, 50% of all nail dystrophy is onychomycosis, caused by fungi, molds, and yeasts. Now, obviously, we understand that onychomycosis is not the only reason for onychodystrophy. This particular study noted a 30 to 40% causation related to onychomycosis, but what about the other 60%? 60% of the time, other causes related to onychodystrophy were listed as congenital nail disease, infections such as bacterial paronychia, skin diseases such as psoriasis and eczema. We'll get to that in a second. Tumors, carcinoma, internal disease manifestations such as lung disease, and of course, trauma. When speaking in terms of psoriasis, it's of note that psoriasis, in addition to onychomycosis, are the two leading causes of onychodystrophy within the nail. The prevalence of nail psoriasis in persons with psoriasis totals 80%. So a very high likelihood if a patient comes in and is positive or has a positive history for psoriasis, there's a good chance that patient also suffers from nail psoriasis. Now, looking at these two pictures, which one of these patients suffers from nail psoriasis and which one of these patients suffers from onychomycosis? If you were to give me the correct answer, I would not believe that you were doing anything other than guessing. Why? Because it is extremely difficult to determine the causes of nail disease when speaking in terms of nail dystrophy secondary to trauma, onychomycosis, inflammatory diseases, psoriasis, so forth and so on. Now, in case you're wondering, the patient on the left suffers from nail psoriasis. The patient on the right suffers from onychomycosis. When you do have a confirmed positive diagnosis for onychomycosis, 90% of the time, that patient is suffering from a dermatophyte, notably T. mentagrophytes or T. rubrum. 10% of the time, when the patient has a positive diagnosis, that patient is suffering from a non-dermatophyte, notably a mold, usually Aspergillus or Fusarium. Now, it's uncommon for onychomycosis to be caused by a yeast, but when it is caused by a yeast, 70% of the time, that yeast is Candida albicans. Now, I just stated that it's uncommon. However, as they say, something may be uncommon, but never zero. This study looked at 111 isolates identified at the species level by culture and PCR for the causative organism. 66 of these patients were positive for dermatophyte T. rubrum. 33 of these patients were yeasts. Now, the previous report just said it's very uncommon for yeast to cause onychomycosis, but as you all know from study to study, these numbers may change. And lastly, 10% of the time, 12 patients, isolates, were identified as molds. The prevalence of onychomycosis is increasing worldwide. The overall prevalence is 5.5%. Again, this is increasing due to increased life expectancy, the increased use of modern footwear, occlusive modern footwear, the increase of obesity, and increased urbanization. Another reason for the increased incidence and prevalence of onychomycosis is its pathogenesis. How does it work? How does it do what it does? Well, for one thing, our nails lack cell-mediated immunity. That's one reason. Also, fungal production of proteolytic and keratinolytic enzymes. The fungal produce these enzymes which break down the nail plate, which help the fungal organism to penetrate the nail and the nail bed. Now, a more interesting anecdote, biofilms. The same way that bacteria produce biofilms to help bacteria evade antibacterial therapies, fungus produces these same biofilms to help fungus evade antifungal therapy. So as you can see, it's hard enough to treat fungus without treating fungus incorrectly because we're treating fungus empirically. There are 5 major clinical presentations of onychomycosis. I've listed them here. I'm not going to spend too much time on them. The first is distal lateral subungual. Now, distal lateral subungual, this is the most common subtype, often caused by T. rubrum. We have white superficial. This is the presentation that many of us have seen. These are the white dots or patches on the dorsal aspect of the nail that you can actually easily scrape off for your nail specimen, often caused by T. mentergophytes. We have proximal subungual, often caused by T. rubrum and or fusarium, which is a mold. This is your HIV patients. The fungus invades the proximal nail and the proximal nail fold. We have endonyx, which is evidenced by the milky patches, indentations, and nail splitting. Lastly, we have the total dystrophic subtype. Essentially, this is end-stage onychomycosis. This is your crumbled nail, your thickened nail. This is the most common subtype and often follows all the other subtypes. Treatment of onychomycosis is closely linked to the identity of the causative agent. Again, the identity of the agent. The treatment is linked to the identity, particularly in terms of whether or not it is a dermatophyte. Now, we oftentimes treat as if we know that there is a dermatophyte. And again, this is a very reasonable statement because again, the treatment should be based on the actual diagnosis. When we don't treat based on the diagnosis, what we get is resistance. We know this from our antibacterial issues that we have. We are creating superbugs all over the place, right? We have MRSA, we have VRSA, we have VRSE. Essentially, there is an incidence in clinical failure of terbinafine. Why? One is because of improper prescribing relative to dosage and concentration and length of treatment, but also there's an increased use. There's an increase of inappropriate prescribing. Again, treating empirically. That coupled with the idea that there are many over-the-counter antifungal agents that patients have access to on their own, that has increased the level of resistance to terbinafine. Again, we are creating antibacterial resistance. In that same vein, we are absolutely creating antifungal resistance as well. Now, what are some of your other treatments that we have options? We have available to us. Well, we have the FDA-approved medications: griseofulvin, itraconazole, terbinafine. Okay, we have some of the topicals. The one topical that is FDA approved is fenoconazole, which is Jublia. I think we're all familiar with that. We have Caratin, Penlac, and then we also have laser therapy. Now we're going to get into a few of these treatments separately. Now, this was a 20-year review, a 20-year meta-analysis. The conclusion of this analysis was that oral terbinafine is the treatment of choice, followed by oral itraconazole. As pertaining to topical therapy, topical monotherapy was only indicated when treating a mild to moderate infection or when oral agent is contraindicated. Why is this the case? Due to poor nail penetration of many of our topical antifungals. Now, these are recommendations following proper testing and proper diagnosis and definitive diagnosis. These are not based on empirical anecdotes. The reason why is because, again, there are risks of empiric therapy. Risks of empiric therapy immediately may lead to misdiagnosis. And then if you have a misdiagnosis, these can lead to unnecessary treatments. There are risks of side effects to some of these medications. There are risks of drug-to-drug interactions with many of these medications, as well as there's an issue with therapeutic failure. And of course, therapeutic failure can lead to the practitioner prescribing more medication, which of course can lead to more resistance, again, which is an issue which we've already discussed. Now I want to get into some of these medications that we do prescribe empirically. I want to make the clear point that prescribing these medications, and we all know this, it is never a benign thing. It's never a benign a benign decision to prescribe a medication. Anytime we're prescribing these medications, especially medications such as terbinafine or itraconazole, it's a good idea to know kind of what we're getting into. Terbinafine specifically, reported adverse events. Now, I love terbinafine. I prescribe it. I'm sure many of you prescribe it, but there are reported adverse events such as taste disturbance, okay, which we'll get into a little bit later, epigastric pain, hepatic dysfunction. Now, I do want to say that, hepatic dysfunction is overstated. The metabolism of this medication in our liver, okay, requires less than 5% of our liver capacity. So the FDA has removed the recommendation that we monitor the livers of all of our patients when they go on terbinafine. We know that. But there is a clear recommendation that if a patient shows up with hepatic dysfunction, we should stay away from terbinafine. We know that. But I just want to make sure, I want to be fair to the medication that, I do believe that the incidence of hepatic dysfunction is dramatically overstated. However, it is a risk, okay? Now, getting back to taste disturbance. This was a study, a case-controlled study, 87 reports of taste loss. The reasons for the taste loss were patients being treated with terbinafine that also suffered a low BMI, okay, a history of taste loss, and aging. Patients were over 55 years old. However, all of these patients regained their taste sensations 4 months after discontinuation of terbinafine. So definitely rare. However, just of note that this may occur. Again, treating with terbinafine or any medication is never a benign decision that we are making as practitioners. Itraconazole should be considered when you have a patient that has failed terbinafine therapy. Also should be recommended or should be considered when you're treating a non-dermatophyte such as a mold or a yeast. However, there are, again, reported adverse events such as headaches. GI upset is a big one. Drug-to-drug interactions is also a big one. Again, never a benign decision to treat with these medications. So if you're going to treat with the medications, we want to make sure that we have a diagnosed reason to treat with the medication. Griseofulvin is another treatment, no longer recommended as the treatment of choice, contraindicated during pregnancy, and the manufacturer cautions against men fathering children for 6 months post-therapy. So definitely not a medication that is recommended at this time. How does one execute on evidence-based medicine? Well, we have to first identify the best available research. We have to use this research in order to optimize our medical decision-making. And then we use this information to develop a best practices approach to patient care. That is, in effect, evidence-based medicine. However, you have to make an accurate diagnosis first. If you don't make an accurate diagnosis, then all of your evidence-based medicine, you can throw it out of the window. So how do we confirm? How do we make sure that we are executing on proper evidence-based medicine? Well, lucky for us, we have laboratory testing options. Right? 3 main vehicles for laboratory testing of a nail plate. Okay, we have histopathology. This is the microscopic evaluation of the nail specimen, essentially determining if an infectious versus a non-infectious agent exists. Okay. Secondarily, now let's go back for a second. When you're testing for histopathology, this does not give you identification of the organism. If you want that, then you have to go to the next arm of laboratory testing. That is the PCR, i.e. DNA. PCR DNA assay. Essentially, this is the molecular analysis of the DNA for identification of genus and species. Okay, this is the test that you have to do if you want, so that you know exactly what you are treating. And then the third option is culture of the nail plate. Now, this is a Petri dish analysis for identification of genus and species. The only problem is very poor sensitivity, as well as it takes a long time. So let's get into the various options for the different techniques for nail specimen collection. So first off, we have our laboratory stains for fungus. Okay, this is your PAS, GMS, and your FM staining. All right, this is your positive or negative confirmation of fungus without organism identification. We'll call these the non-DNA testing techniques. We have the PAS stain, which stains the cell wall of a living fungi. You have the GMS stain, which stains carbohydrates and sugars of living and or dead fungal organisms. Again, essentially, you're looking for the detection of your fungal hyphae. These two tests together offers the highest level of sensitivity for living and decayed fungus. Very important note is that, again, these tests do not offer genus and or species, okay? This is just giving you a yes or a no if fungus exists. Next, we have the FM stain. This is a sensitive test for melanin pigment in fungi. Also validates the presence of a melanocytic process, looking for melanoma, matrical melanocytic macules, so forth and so on. All right, now the second arm. This is your onychodystrophy DNA test. This is your PCR assay. All right, the polymerase chain reaction study detects genetic fungal DNA. This test will provide you with genus and species. This is the crux of everything that we've been talking about so far in this webinar. Essentially, if you're going to treat, especially if you're going to treat with an oral medication, you should definitely know specifically what you are treating before you give a patient an oral medication. Very high specificity, again, organism identification. Now, I do want to say another very important note that when you're doing a PCR test for genus and species, this is not an either or situation. It's not a situation where if you do the PCR, you don't do the PAS or the GMS. All right, these tests work in tandem, and I'm going to give you a couple of studies that kind of promote that. Okay, these tests work in tandem. Now, T. rubrum and T. mentecrophytes represents approximately 27 to 45% of nail dystrophy. So what about the rest of the time? Again, you definitely want to know what the organism is. The organism only 27 to 45% of the time is going to be a dermatophyte, say T. rubrum or T. mentecrophytes. Well, what about the rest of the time? You have the aspergillus, you have the fusarium, you have, the Candida albicans, you have all the other options. What about those? As for your DNA test, your PCR assay, how is it performed? Well, first off, you take a nail sample, a dry nail sample, okay? There is an initial DNA screening that occurs, okay, looking for a dermatophyte, a saprophyte, or a yeast. Now, if that initial screening is negative, no further testing occurs. However, if that initial screening is positive, there is a second level study, a second level reflex study that is looking for causative organisms for onychomycosis. Again, causative organisms, not non-causative organisms, are a very important point because I want to make it clear that there are no wasted resources and wasted time and wasted money, okay, looking for all these other organisms that don't readily cause onychomycosis. So that's a very important point. Now, what and how do I make my decisions for when and how I do my testing? Well, in my office, if I have a patient that I've already identified an organism 2 years ago and the patient returns, or a year ago, the patient returns with a recurrence, that's a patient I'm probably just going to do a PAS stain. All right. I already know what the patient has, or I have a high clinical suspicion of what the patient has, or because of what they had. So that's a patient I'm probably going to do a PAS or a PAS and a GMS stain concurrently. Now, if I have a patient that I treated a year ago and I bring the patient back and I do a PAS stain or PAS GMS and then it's negative, all right, well, there's a high clinical suspicion that the patient has onychomycosis. So that's a situation where I would do a repeat study, a PCR study alone. Okay, very rare situation, but it does happen. But that's that situation. Now, when would I do a comprehensive nail analysis? 4 main reasons for this. Number one, patient returns, or the patient presents to my office from a different office where he or she had a failed treatment. So now I don't want to put the patient on any more medication unless I know exactly what I'm treating. Okay, especially if I don't have any data from the other office as to what I'm treating. I'm definitely going to do a comprehensive nail analysis. Again, and for me, that is a PAS, GMS, and a PCR. Second reason, excuse me, if a patient is a repeat offender, someone I may have treated 5 years ago and before I was doing PCR studies. Now I have no idea what this patient has. The patient is a repeat offender. Then I want to get the exact information. Thirdly, a patient that presents with aggressive nail disease, okay? Aggressive nail disease, I'm going to do a comprehensive analysis. And lastly, if a patient tells me they are absolutely interested in doing oral treatment, I'm definitely not going to give anyone oral therapy unless I know exactly what organism I am treating. Now, a couple of studies that speak to that end. We have our first study here from Javan 2020. 209 patients with clinical diagnosis of onychomycosis. Quick note, 6 patients were excluded due to insufficient sample size. In much the same way as when we collect our specimens in our office, we have to make sure that we have an appropriate sample of nail plate, because if you don't, you may receive an inconclusive result the same way that patients were excluded from the study. All right. So just make sure, we're going to talk about nail specimen collection here shortly, but just that's one note that is very important. All right. So now 109 patients tested positive in this study utilizing PAS staining. 77 patients tested positive using PCR DNA assay. The recommendation from the study was combination testing was appropriate in all scenarios. Second study here, 149 patients were tested for onychomycosis. 142 of these patients were positive for T. rubrum, T. mentacrophytes, and T. interdigitale via PCR DNA assay. Only 104 of these specimens were positive utilizing fungal culture. Among the 28 culture negative specimens, 23 of these were positive for T. rubrum. 4 of these were positive for T. mentacrophytes utilizing PCR. So the PCR was superior relative to sensitivity as well as timing. PCR results came in 2 days versus culture results, which came in 28 days. We've discussed etiology. We've discussed diagnosis. Now we should discuss technique. So when you're doing a nail specimen collection, there's a certain technique that you want to maintain. Okay, the first part, and maybe one of the most important parts, because you don't want to return an inconclusive report, you want to remove and discard the distal nail. All right, you can't use that. Remove that distal. Assume that's just a distal nail clipping that may not have the important fungal hyphae that you're looking for. You want to obtain the proximal nail and the hyponychium. That's where the fungal hyphae exists that will likely give you a positive report. All right, that's what you want to attain. Looking at this microscopic picture here, the upper left-hand picture, you can see the under surface of the nail plate, and you can appreciate all of the ridges there. Those ridges is where the fungal hyphae exist. The upper right-hand picture there, you can see this cylindrical fungal hyphae, which is extending from the ventral side of the nail plate. Okay, the second picture. All right, you can see upper right-hand corner of this second picture, you can see the fungal hyphae, which is embedding itself into the nail bed. All right, so that's what you're looking for. You're looking for that fungal hyphae as it extends from the nail plate, the undersurface of the nail plate, into the nail bed. All right, so evidenced by this subungual debris. So not only do you want to attain the proximal nail plate, but you want to obtain that proximal subungual nail debris as well, because again, that's where the fungal hyphae exist. You want to send all of that in your dry keratin nail bag. You have a couple of my cases here I'm going to present real quick in closing. Okay, this patient, status post 90 days treatment. This patient has been treated with terbinafine 250 again for 90 days. You should be able to appreciate that approximately 50% of this nail has cleared of this onychodystrophy. Upper left-hand corner, this was my PAS GMS stain, and as you see, it was negative. Okay, it was negative. Had I stopped there, I would have just assumed this onychodystrophy was from trauma or from some other non-fungal organism. All right. But I did do a PCR DNA assay on this patient, and it was positive for T. rubrum. OK, positive for T. rubrum. Therefore, I treated the patient for 90 days with terbinafine. And right now we're about 50-60% there. Second case here. upper left-hand corner, we did our PAS GMS stain. It was positive. And then we proceeded to do our PCR DNA assay. And as you can see, the PCR assay was positive for Aspergillus and Fusarium. And then based on the paper that I presented before, the recommendation when treating Aspergillus and or Fusarium is itraconazole, and that's what I used. This patient did not suffer from any hepatic disease, so I used the itraconazole 100 milligrams PO, and as you can see here, we're about 70 to 80% clear of onychodystrophy after 90 days. And lastly here, my last patient. This is, I saw this patient in my office about 3 weeks ago. Upper left-hand corner, you can see my PAS GMS was positive for moderate fungal growth. And bottom right-hand, you can see my PCR DNA assay was also positive for T. rubrum. Again, T. rubrum, T. mentacrophytes are the organisms that you will see the most. But again, there are many other options, many other reasons for why a patient will suffer onychomycosis, and you definitely want to perform your proper testing to determine what those organisms are. This patient has not started treatment. She is trying to decide if she wants to treat this topically or orally. So in closing, these are my onychodystrophy considerations. Again, laboratory testing is of paramount importance. This removes the risks of empiric therapy. All right. This allows for targeted therapy, which leads to a decrease in multiple treatments. And above all else, increases the patient satisfaction with you and the confidence that they have in you. I know specifically if I go to a doctor for a failed treatment, and then I go to a second doctor for a second opinion, if that doctor does a biopsy or does some additional diagnostic testing, that's going to increase my confidence in that doctor immediately, because I'm going to think that doctor took the necessary time to get to the bottom of what my problem was. And then above all else, if you take care of your patients, they will send you referrals. This is a referral source. You are the doctor that solved their problems by taking just a little bit more time and paying a little bit more attention to what their issue was. So hopefully this webinar helps you out and gives you the tools that you need for a proper testing technique and organism identification. So thank you for your attention. And above all else, please stay safe. Thank you.